Peritoneal mesothelioma treatment depends on the stage of cancer and the overall health of the patient. The main treatment options for peritoneal mesothelioma include surgery, chemotherapy, radiation therapy, and targeted therapy. Often a combination of these treatments will be recommended by the medical oncologist. Surgery is often the first-line treatment option for early-stage peritoneal mesothelioma that has not spread widely. The main surgical procedure is known as cytoreductive surgery or debulking surgery. The goal of this surgery is to remove as much of the visible tumor from the peritoneum as possible. During the surgery, the surgeon will make a large incision in the abdomen to examine the peritoneal lining and organs for tumors. All visible tumors will be removed along with portions of the peritoneum where cancer is found. Sometimes portions of the small intestine, colon, or other organs involved with tumor growth need to be surgically removed as well. Following cytoreductive surgery, the abdomen will be washed or flushed with a heated chemotherapy drug to kill any remaining cancer cells. This is known as hyperthermic intraperitoneal chemotherapy, HIPEC. The chemotherapy drug is circulated inside the abdominal cavity for 30 to 90 minutes while the abdomen is closed. This allows very high doses of chemotherapy to be delivered directly to the peritoneal cavity where tumors are likely still present, even if not visible. Cytoreductive surgery combined with HIPEC has been shown to provide the best chance of prolonged survival for patients with peritoneal mesothelioma. For those unable to undergo such an extensive surgery or whose cancer has spread too far, systemic chemotherapy will typically be the primary treatment option. Platinum-based chemotherapy drugs, either alone or in combination, are most commonly used to treat peritoneal mesothelioma. The standard first-line treatment is a combination of pemetrexed and cisplatin. This combination has been demonstrated to improve symptoms, disease control rates and survival compared to cisplatin alone in clinical trials. Carboplatin may sometimes be substituted for cisplatin depending on patient tolerance to side effects. Other chemotherapy drugs that may be used alone or in combination include doxorubicin, gemcitabine, and mitomycin. Chemotherapy is typically given through and for every 3 to 4 weeks for a total of 4 to 6 cycles depending on tolerance and response. The goal of chemotherapy is to slow cancer growth and spread. It is also sometimes recommended following cytoreductive surgery to destroy any remaining cancer cells. For some patients with early-stage cancers, radiation therapy may be recommended in addition to surgery to further boost treatment effectiveness. External beam radiation therapy is usually the type utilized. High-energy X-rays are directed at the area where the tumor was removed or is suspected to have spread. The goal is to kill any tumor cells that remain locally in that part of the body. Radiation is typically given daily in fractional doses over several weeks. It may be given before or after surgery depending on the specific case. For advanced stage cancers that have spread or returned following initial treatment, targeted therapy drugs may offer another treatment approach. Pemetrexed itself acts as an anti-folate, anti-metabolite chemotherapy drug, but also has anti-angiogenic properties. Anti-angiogenic therapy blocks the formation of new blood vessels that tumors need to grow. Bevacizumab, Avastin, is the primary anti-angiogenic drug tested in mesothelioma clinical trials so far. It acts by inhibiting signaling of vascular endothelial growth factor, VEGF. Other novel targeted therapies still in early testing phases include immunotherapy drugs known as checkpoint inhibitors. These drugs help block mechanisms tumors use to evade detection and destruction by the immune system. Drugs like nivolumab and pembrolizumab are among those being studied. Targeted therapies are usually given along with chemotherapy to offer another layer of disease control. After undergoing any treatment for peritoneal mesothelioma, follow-up surveillance is crucial for monitoring response and checking for recurrence. Follow-up appointments with medical oncology, yearly CT or PET scans are standard following initial therapy. Any recurrence or spread will usually be further treated with additional rounds of systemic chemotherapy as long as the patient remains healthy enough. A second debulking surgery may occasionally be attempted if the new tumors are still localized. In some cases, Enrollment in a clinical trial of new investigational therapies may also be recommended. The long-term prognosis for peritoneal mesothelioma remains poor despite treatment advancements in recent years. The overall 5-year survival rate is approximately 10 to 15% for cytoreductive surgery plus HIPEC. Thus, palliative care and symptom control also remains an important component of ongoing management for many patients. Treatment planning for peritoneal mesothelioma is complex and relies on surgical site reduction combined with intraperitoneal chemotherapy whenever feasible for early-stage disease. Systemic platinum-based chemotherapy represents the standard non-surgical treatment. Radiation may play a supplemental role, and targeted therapies offer new treatment modalities in recurrent or advanced settings. A multidisciplinary team approach involving medical and radiation oncology, surgery and palliative care specialists is recommended to achieve the best patient outcomes and quality of life. Future progress will depend upon refining existing therapies and testing newer investigational agents in clinical trials.